Hello, everyone. Thank you, Emily, for the information and introduction. And thank you, everyone here, for joining me today to talk about exposure therapy for anxiety disorders. So my name's Sandy Capaldi. I'm actually an assistant professor in the psychiatry department at University of Pennsylvania. I'm the associate director at the Center for the Treatment and Study of Anxiety, or the CTSA, at Penn. At the CTSA, we specialize in treating anxiety and related disorders. So in our presentation today, I'm going to be talking about really what makes up the bulk of the clinical work that we do at the CTSA. Just to give you all an idea of how things will work, we'll be together until 4 o'clock today. And what we'll do is we'll take 2 breaks throughout, just like brief 5-minute breaks after we've been working for a little while, just to allow people to use the restroom or get a drink or just move around, so you're not sitting here for hours at a time. Okay, so in thinking about getting started with talking about this stuff, the first thing is to kind of put what we do at the CTSA and what, treating anxiety, to kind of put it in perspective. I think we have to first recognize that there are literally hundreds of different types of psychotherapies out there. Most types of psychotherapy focus on helping a client to achieve some kind of psychological change, and they're usually grouped according to their theoretical underpinnings. And many of them fall into one of several categories that are kind of highlighted in this word cloud here, the larger ones. So like, let's take psychodynamic psychotherapies, for example, right? That approach focuses on change by discovering a person's unconscious meanings and motivations. Many of you, I'm sure, have heard of Sigmund Freud, right, and psychoanalysis, which was called like the talking cure at first. It's actually the first type of psychotherapy ever invented, which is kind of a cool bragging rights for psychoanalysis. Humanistic therapy is an approach that emphasizes people's capacity to make rational choices and like develop their maximum potential. One type of humanistic therapy that's especially influential is client-centered therapy. You may have heard of that, which really rejects the idea that the therapist is the authority on the client's inner experiences. And instead, the therapist helps the client to change by emphasizing their unconditional positive regard for the client. Behavior therapy is another approach that focuses on the role of learning in developing both, adaptive and non-adaptive behaviors. You may have heard of or remember Ivan Pavlov and his contributions to behavior therapy when, discovering classical conditioning. We'll talk a little bit more actually about Pavlov in a few minutes. And there's also Thorndike, who discovered operant conditioning, where, kind of the learning relies on rewards and punishments to shape people's behaviors. Some of what we will often do with kids, right, in providing rewards to help make behavior more likely to happen. Now, cognitive therapy is closely aligned with behavior therapy, but it emphasizes what people think rather than what they do. So it's kind of the idea that the dysfunctional thinking leads to dysfunctional emotions or behaviors. So by changing thoughts, people can change how they feel and what they do. Now, several variations of cognitive and behavioral therapy have been developed, over the years. And one of those variations is cognitive behavioral therapy, which is where what we're going to be talking about is really focused on cognitive behavior therapy, or CBT, for anxiety disorders. Now, what you'll notice as we talk today is that when we're treating anxiety disorders, it tends to be kind of a little C and a big B. That is, our interventions are often targeting behaviors and changing behaviors. And the belief is that the cognitive change is going to follow the behavior change. Again, we'll talk more about that later. First, let's think together about how CBT is a little bit different than some of the other types of psychotherapy out there. So first, it's time limited. So most CBT protocols are, 8 to 20 sessions in length. Okay. They're highly focused, which helps contribute to the time limitedness of the therapy. They're also structured, meaning there's an agenda and there are goals set out for each session of treatment. CBT sessions are generally focused on present day concerns, like in contrast to psychodynamic therapy, where you would be thinking more about your childhood, your relationship with your parents, that sort of thing. CBT is focused on present day stuff. It's also an active treatment, meaning both the therapist and the client are actively engaged in the session. There isn't an expectation that the client is just going to sit and talk for an hour, but rather that, both parties, the therapist and the client, are going to be engaged in discussion and other tasks of therapy. And finally, CBT involves homework. One of the foundational principles of CBT is the idea that lasting change isn't going to occur in just 1 hour per week, but that thought and effort related to the presenting problems needs to be put in outside of the session. So now that we know what distinguishes CBT from other types of therapy, let's take a look at some of the common components of CBT. Okay. Oh, I was wondering why those were all dark. Somehow a little animation got in there. Okay, so we're going to talk about each of the components of CBT individually, but you can see here I've laid them out. CBT for anxiety typically includes assessment, psychoeducation, cognitive restructuring, relaxation, exposure, and homework. Okay, so let's start with assessment. Okay. Now, the purpose of assessment is to identify the presenting problem that is primary and that is in need of treatment. So primary basically means that it's the problem that's distressing the client the most, interfering most with their functioning, and is the problem that the client wants to work on. It's kind of important that all three of those criteria are met in order to get the most, bang for our buck in treatment. It's important to accurately assess for diagnosis and comorbidities in order to really, effectively plan treatment. In CBT, treatment is disorder specific, again, which contributes to the time limited and efficient nature of the treatment. And really for anxiety, identifying the person's core fears and what's maintaining those fears is also very important. That's going to be, really key in planning, effective treatment. So in CBT, we use a mix of interview and self-report measures to kind of achieve these goals. Now, for both types of assessment measures, we use both general and specific measures as well. So one good general interview that we use is called the DIAMOND, the Diagnostic Interview for Anxiety, Mood, and Obsessive Compulsive and Related Neuropsychiatric Disorders, which is why we usually just say the DIAMOND. It's a lot to say. So this is a semi-structured diagnostic interview for DSM-5 psychiatric disorders and has sections and questions for most of the major things that you're going to see clinically: anxiety disorders, depressive disorders, bipolar disorders, obsessive compulsive and related disorders, trauma and stressor related disorders, even like schizophrenia spectrum, other psychotic disorders, eating disorders, substance related disorders, some of the neurodevelopmental disorders like ADHD and tic disorders, and suicidality. Now, for all of these things, it includes screening questions that helps to narrow down the focus of the interview. So if a client endorses the screening question, the clinician then goes through the entire module for that disorder. But if they don't, then they can skip those sections. Now, for some disorders, there are also specific interview measures like the Y-box for OCD or the PSSI-5 for PTSD. And again, we like to use some of these specific measures to get more information about the severity of, any individual treatment plan that we're making. As an adjunct to our interview measures, we also use self-reports. again, both general and specific, that help to screen for particular symptoms, importantly, to track progress throughout treatment. So for example, if we're treating someone for PTSD, we'll ask them to complete the PDS-5, which is a PTSD measure, of a self-report measure. We'll ask them to do that every other session to track their PTSD symptoms. Now, once our assessment is complete, we've identified the primary problem, we've got a treatment plan in place, CBT usually first begins with psychoeducation. Now, psychoeducation, our goal is really to, help to establish that alliance, right? To build alliance by letting the client know that we understand their situation, and also to help educate them about the process of CBT. So first, we'll usually educate them about the disorder that we're treating. We'll review the symptoms, we'll discuss like epidemiological data, how frequently the disorder occurs in the population. We'll present treatment options and, potential outcomes. And this helps to normalize the symptoms they're experiencing, by saying many people experience these symptoms. It makes a lot of sense for them to be occurring in this context, while at the same time instilling hope by pointing out how the treatment is going to be, that we'll be doing is really designed to target the symptoms the client's experiencing and to reduce them. I mentioned psychoeducation also includes a discussion of how CBT works and the rationale for how it works, which we'll talk about in more detail a little bit later too. In this phase of treatment, which is typically just 1 or 2 sessions, the homework includes some kind of self-monitoring of symptoms, like monitoring the number of panic attacks a person is experiencing, or the number of compulsions that they're performing if we're treating OCD. Right? Another important component of CBT is cognitive restructuring. So with cognitive restructuring, we help the client to identify automatic thoughts, which are thoughts that are kind of instantaneous, habitual, and sort of non-conscious. They often affect a person's moods and actions. So helping a person to become aware of the presence and the impact of these kind of negative automatic thoughts and to counter them is one of the main tasks of cognitive restructuring. Now, I've included here some common examples of cognitive distortions, which are these common patterns and errors in thinking. So for example, all or nothing thinking, right, which refers to kind of thinking in extremes. You're either a success or a failure. Your performance was totally good or totally bad. If you're not perfect, then you're a failure, right? These kinds of thoughts, this sort of binary way of thinking. There's only 2 options, which doesn't account for shades of gray, right? And then set someone up for a feeling of failure, right? Now, we don't have time here to talk in detail about all of these, but you can review these for yourself at some point if you're not already familiar with them. I've also included a couple more here, right? So should thinking, personalizing, labeling, etc. So there's a bunch of different commonly seen patterns of cognitive distortions. Now, when we've sort of helped the client to identify these automatic thoughts, we can use Socratic questioning to help them to evaluate the accuracy or the helpfulness of these thoughts by asking them to identify, the evidence for and against the veracity of the thought, the truthfulness of them, identifying alternative explanations, thinking about the implications of the thought if it is indeed true, right? Through this process, we're helping the client to develop more helpful ways of thinking. Now remember, this is occurring both in session and at home for homework using thought logs. Okay? So now let's turn our attention to another component of CBT for anxiety disorders, which is relaxation training. Most people that experience anxiety will experience unpleasant physical sensations pretty regularly. Some of the most common physical symptoms of anxiety include muscle tension, headaches, backaches, clenched jaw, feeling keyed up or restless, on edge, having difficulty concentrating. So the goal of relaxation exercises is to change the baseline levels of those physical components of anxiety to a lower level. But we should think of relaxation skills just like we think about exercise for our physical health. In order to see significant results, we have to use them regularly over periods of time. This isn't a one-shot deal. Relaxation strategies are really best used as a companion to exposure and cognitive skills, not as a replacement for them. In fact, sometimes relaxation strategies, if we use them alone, they can actually make anxiety worse in the long run. Because people use them as a way to get rid of anxiety. And trying to get rid of anxiety really trains our brains to see it as bad. And anxiety in and of itself is actually not a bad thing. So trying to make it go away by using relaxation exercises alone is therefore not helpful. So there's times and places for relaxation skills, but it's really best to, have clients use them on a regular basis, just as you would, regularly exercise, again, to help with physical health. You can regularly practice relaxation exercises to help with mental health. Now, the final component of CBT that we're actually going to be spending most of our time today talking about is exposure. Exposure involves helping a client to approach their unrealistic fears in order to learn that their fears either won't come true or that it was, excessive or exaggerated. With exposure, we first identify the thoughts, activities, situations, people, places, etc., that the client fears, and we rate them according to level of difficulty or distress. We'll talk a little bit about subjective units of distress in a minute too, and how we use those. But once we've kind of ranked these situations and rated them according to how difficult they are, we begin with something that's moderately distressing, and we work on each situation, moving up the hierarchy. It's important in exposure to make sure that the client psychologically engages in the exposure. They don't try to distance or distract themselves in order to avoid it or to feel safer. And really, exposure is, the cornerstone of treatment for anxiety. So we're going to talk a little bit in detail about how exposure works and why it works. So first, in CBT, we talk about what we call the cognitive triad, which refers to the interplay between our thoughts, behaviors, and emotions. So as this graphic here illustrates, CBT believes that each of these factors can influence one another. Our thoughts, what we think, can influence our behaviors or what we do. Our thoughts can or similarly, what we do can influence what we think and how we feel. And how we feel can also influence what we think and what we do. So all three of these factors are interrelated. And theoretically, we can intervene on any one of these levels and see changes in the other two, right, by the way this is set up. In exposure therapy, we're choosing to intervene at the behavioral level. So that is, we're choosing to ask people to change what they do in order to change how they think and what they feel. So let's take a look at the concept of learning theory. We were talking about Pavlov a little bit earlier, and see how this evolved and how this developed. So who here remembers Pavlov or remembers his dogs, learning about his Pavlov's dogs in school? Anyone? Yeah? See some nods? All right. So Pavlov, if you remember, he was one of the foundational thinkers in behavioral learning theory. His idea was that you could condition learning. So he did an experiment where he measured how much saliva dogs produced when they were presented with food. Salivating when food is presented is a natural response and what he termed an unconditioned response. The food itself was therefore an unconditioned stimulus. It naturally caused the dog to salivate. What Pavlov did was he started to first ring a bell before bringing out the food. And time again, he rang the bell, then brought out the food. Guess what started to happen? The dogs associated the bell with food and began salivating even just when the bell rang, before the food came out. So the bell became a conditioned stimulus. The bell alone could elicit salivation even when there was no food present. Now, if you have any pets of your own, you may see this kind of conditioning at work too. So like I have a cat. Anytime anyone in the house opens a can, doesn't matter if it's tomato sauce, tuna fish, sometimes it is cat food, but anytime we open a can, we'll be sure to see the cat prancing in, thinking it's time to eat because the sound of a can opening has become associated with eating for him, okay? So you might be thinking, what does this have to do with anxiety disorders, right? We're talking about cats and dogs. What does this have to do with humans even? Well, this is where John Watson comes in, who's another foundational thinker in behaviorism. Watson wondered if he could use this kind of conditioning called classical conditioning to elicit another kind of natural response, right? So Pavlov elicited a natural response of salivating. Watson wanted to see if he could elicit a fear response. So they took a 9-month-old baby called little Albert for an experiment. Now, this would not be allowed today ethically to do a kind of experiment like this, but this was, way back in the, 50s or 60s. So we didn't have the kinds of controls that we do over research. But Watson followed, basically the same procedures that Pavlov had used in his experiments with dogs. Before the experiment, little Albert was given a bunch of kind of baseline tests where he was exposed to a white rat, a rabbit, a dog, a monkey, different kinds of masks that had, some had hair on them, some didn't, cotton, wool, burning newspapers, all sorts of different things. And they sort of, looked at and watched little Albert's reaction to these things. And during these baseline tests, he showed no fear of any of these items. He had no reason to fear them, and he had never been exposed to them before. Now, for the experiment, they put him, in the middle of a room and put the rat near him, and he was allowed to play with it. Okay? Whenever Albert reached out to play with the rat, Watson and his assistant would strike a steel bar with a hammer, making a really loud noise and frightening little Albert. Right? So every time he touched the rat, they would make this loud noise. And what do you think the baby did? He started to cry, right? And started to show that he was afraid of touching the rat. Now, after they did this several times, where they would hit this steel bar and make this poor little baby cry, they started to just present the rat without hitting the steel bar. But now, when Albert saw the rat, he'd become very distressed, right? Cry, try to crawl away from the rat. So he started to associate the rat with the scary noise, and therefore the rat, which was originally kind of a neutral stimulus, had become a conditioned stimulus. It was an eliciting, an emotional response similar to the response that he had given during, when he saw the noise. So he was afraid of the rat, even though he hadn't been before. Now, they also did further experiments where, they looked at some of the other things that they had presented him before to see if he generalized that fear. And they found that other kind of furry objects, like the rabbit, the dog, even like a Santa Claus mask that had white cotton balls on it, he was afraid of those things too. The fear generalized to kind of, white furry things, right? Now, again, you may be thinking to yourself, how is this related to anxiety disorders? Well, this next slide shows both the acquisition of fear, right? Now here in this example, there's a rat being conditioned to be afraid of a sound because the sound is paired with a shock. And we want to, also be able to extinguish the fear, right? And so to extinguish that fear, the experimenters in this experiment would, play the sound over and over again without shocking the rat so that the rat would learn not to be afraid of the sound anymore. So again, that would be the same thing that they would have done with little Albert is, keep presenting the rat without the sound and they would see that he would not be afraid anymore. So at its most basic level, these two procedures of like fear acquisition and extinction learning are actually what are really at play in anxiety disorders and their treatment. So an individual develops fear or anxiety through some learned experiences, and then treatment is designed to extinguish that fear by presenting the harmless stimuli repeatedly to show that it's not actually associated with danger. Now, the theory that puts that all together to explain the development and the maintenance and the treatment of anxiety disorders is called emotional processing theory. An emotional processing theory is really based on the idea that fear is represented in memory as a program for escaping danger. And, this kind of fear structure includes different kinds of information. It includes information about, what it is that we're afraid of. For a person with contamination fears and OCD, let's say, an extremely gross toilet like this one, okay? The fear structure also includes fear responses. So when you see this gross toilet, your heart rate starts to increase. And the meaning associated with these things, like dirty toilets are dangerous. And the meaning associated with the response, the fact that my heart is racing means I'm afraid. Now, when a fear is realistic, we call it a normal fear, and the fear structure contains information about how we can best respond to this real threat or danger. So feeling grossed out or afraid if we see a toilet like this and avoiding using it are appropriate responses, right? This can be seen as normal and a helpful fear reaction. I don't think anybody would want to use this toilet here, right? When a fear structure becomes a problem, though, that's when the information in the structure doesn't accurately represent the world. And these kind of physical responses and the desire to escape or avoid the situation is triggered by harmless stimuli, like refusing to use this toilet, which looks relatively clean, or to, spend hours cleaning it each day when it looks like this. Okay? So it's a problem when these fear responses interfere with daily functioning. Like, let's say a person isn't able to work because they're spending so much time cleaning a bathroom that looks pretty clean already and is pretty clean already. And it's a problem when, these kinds of harmless stimuli and responses, right, like a clean toilet, is seen as dangerous. Okay, so that kind of the emotional processing, helps to explain how these kinds of, things that would be typical, right, can generalize to the things that actually aren't scary, aren't dangerous, like we said, like this, clean, relatively clean toilet. So why do anxiety disorders persist? Well, emotional processing theory, says that this chronic avoidance, this chronic, trying to escape these kinds of things, often leaves these, unhelpful, maladaptive fear structures in place because people don't stay in the situation long enough for any kind of new learning to occur. Now, for people with anxiety-related problems, there are really two common beliefs about the feared stimuli. One is that the anxiety or the distress is going to escalate to a degree that it becomes unmanageable. And two, that the thing that they're afraid of, or even just the experience of anxiety, will cause harm to them. So like, I'll lose control or I'll go crazy, right? For example, someone with panic disorder, right, might think, I'm going to die, when they start to notice their heart racing or, that they're short of breath. Okay. So the major problem, according to emotional processing theory, is that people with anxiety disorders engage in some form of escape or avoidance behaviors when they feel anxious. And as a result, they don't remain in contact with the anxiety long enough to disconfirm the fear structure. So over time, people will continue to, engage in those kinds of behaviors whenever they experience fear. And an unfortunate side effect of this, like continued avoidance, is that people's lives begin to constrict in order to avoid things that trigger those fear structures. So their lives become narrower, more confined. Maybe they even stop leaving the house. So how do we intervene? How do we keep that from happening? Well, exposure therapy is, as we said, kind of treatment that encourages systematic confrontation with these feared situations. This can be internal, external, right? And the aim of exposure therapy is to reduce the person's fearful reaction to the situation or the stimulus. So successful treatment is going to involve providing the client with experiences that disconfirm that pathological fear. And disconfirming these feared outcomes occurs through the exposure techniques as well as the cognitive change that occurs as a result of learning that happens. And these feared outcomes can be, anything from mundane kinds of things to catastrophic, right? And the person, needs to learn that they can either survive the feared outcome or that they can live a life while still assuming the risk of catastrophe, right? Nothing in life comes without risk. Okay. And so it's, being able to live with the idea of risk. So the solution for emotional processing theory is for people to stay with their anxiety long enough for it to reduce on its own. Research suggests that, as long as we don't actively feed anxiety, it goes down on its own after, about 45 minutes, which is what we call habituation, right? Kind of getting used to, or your anxiety or distress going down. Now, through repeated habituation, the person learns that what they were afraid would happen, like I'll go crazy, for example, doesn't occur. That the feared consequence are less likely to occur, or they're milder than they're expected. It wasn't as bad as I thought it was going to be. So exposure is really an opportunity to learn new associations between those things that we're afraid of and our reactions to them. And CBT and exposure therapy and CBT is tailored to the, target disorder, whatever it is we're working on, and their presentation. So the techniques that we're using really depend on, the person, what we're treating and their underlying fear. In order for exposure therapy to work properly, there are two necessary conditions. So let me give you a quick example to illustrate this. Let's say we have a person who is afraid of large, scary-looking dogs, okay? And they, have learned that these types of dogs, these big, scary dogs, can be dangerous, right? They know people who've been attacked by dogs, although they were never attacked themselves. And they, are so afraid of this that, again, they start constricting their life, right? And so first it's, maybe they don't go to the dog park or places where people walk their dogs. And soon they're not leaving the house at all, for fear of running into a dog. So they go for help, they go for exposure therapy. And, the therapist says, we know exactly how to treat this, right? What we have to do is we have to get you to, approach dogs, right? Simple as that. And so the therapist finds a dog to help participate in this exposure therapy. And he gets, a cute little puppy as a first step. So he brings the cute little puppy into the session, and the client looks at the puppy and he says, "That puppy's adorable. How cute. Let me give him a hug. Let me pet him." And the therapist is kind of baffled. Wait a minute, I thought you were afraid of dogs. And the client says, "Well, I told you I'm afraid of big, scary dogs. Like, who's afraid of a puppy?" Right? So here, the problem was that we weren't accessing that fear structure, that emotional structure, right? The emotional structure was around big, scary dogs, not dogs in general, right? So the therapist wasn't listening closely enough. So the therapist says, "Okay, I'm sorry, this was my fault. I wasn't listening closely enough. I will find us a nice, big, scary dog to work with for the next time." And so for the next session, he brings, a big, scary looking Rottweiler, let's say. And the client sees the Rottweiler, and immediately you can see that, he's visibly shaken, right? He's scared, he's shaking, he's, not wanting to go near the dog. So the therapist works with him on gradually getting closer to the dog, right? Maybe they stand at the doorway to start with, and then they move closer and closer to the dog until they're right next to the dog. And the therapist encourages the client to, go ahead and pet the dog. And the dog bites him. Well, now this isn't good exposure therapy either, because the feared outcome came true, right? And so we didn't provide, in that example, corrective information, right, to modify the belief that the client had that these big, scary dogs are dangerous and are going to attack you. So what we need, right, for good exposure therapy is accessing that fear structure, making sure that we've got something that is related to what the person is afraid of, but also something that is relatively safe and is going to provide corrective information. And so if we find a big, scary looking dog, we have to make sure that it's, a sweet, cuddly dog that isn't going to bite or nip at someone, so that they get that corrective information. Right? So let's break down what happens when a person engages in exposure therapy. There's a lot going on, when this is happening. So first, it helps to break the cycle of avoidance. Now, avoidance is a decent short-term strategy because it usually helps anxiety to diminish in a relatively short period of time. The problem is it's not a great strategy in the long term because it doesn't allow for learning to occur. For example, learning that what you're afraid of doesn't actually happen, which you can't do unless you do it, right? So by actually doing things instead of avoiding them, you start to break that cycle and see that the situation you were avoiding is not actually dangerous. And as a result of doing instead of avoiding, you also get to see that your distress and anxiety diminishes on its own, and that anxiety actually can't last forever. Also, by doing instead of avoiding, you feel more control over your life. You're controlling what you do instead of the anxiety controlling what you do. And you see that you're actually able to handle situations that you previously thought you were not able to handle. Now, there's 4 different types of exposures. Okay? We have in vivo exposure, or real life, in life exposures. These are actual places, situations, objects, activities that we'll ask people to approach rather than avoid. We've got imaginal exposure. So when in vivo exposure isn't possible or ethical or safe, we'll ask clients to engage in imaginal exposure, which is where they expose themselves to the content of their fear in their imagination through like narrative or storytelling means. We have interoceptive exposure, which is a type of exposure to physical sensations. In this type of exposure, we ask clients to engage in activities that create or simulate physical sensations that elicit fear or avoidance for them. A final type of exposure is virtual reality exposure, where individuals are fitted with, virtual reality goggles, etc., and can face their fears in that way. Now, interestingly, real life or in vivo exposure is usually found to be more effective than virtual reality exposure when we're able to access the real life things. So virtual reality exposure isn't typically a first line treatment, especially in light of, needing special equipment, software, programming, et cetera, to be able to do it. It's much easier to be able to, go find a dog to do an exposure with rather than to try to get somebody to program a dog into a virtual reality kind of system. Okay. Now, I mentioned this before, and I'll say it again because it's important that, what we typically try to do is use a scale to allow the client to easily and quickly kind of communicate their distress. So we use subjective units of distress. The scale goes from 0 to 100. We can use increments of 5. You can also use 0 to 10 if that's more comfortable for you or your client. Now, on the subscale, 0 is completely calm and relaxed. 100 is the most distress one has ever felt. So we teach clients about this scale, and we ask them to rate their distress as related to how they think an exposure is going to be, as well as to rate it when they're doing it, to keep track and check on how they're feeling and whether or not habituation is occurring. So before we're going to talk about specific treatments for individual anxiety disorders. But before we do that, let's talk a little bit about the efficacy of CBT for anxiety disorders, right? The evidence base. So we know that there is a lot of research evidence showing that CBT is very effective in the treatment of anxiety disorders, and that these psychological treatments are equally effective and even superior to medication in the long term. Yet, evidence-based CBT and exposure therapy isn't widely used by the majority of clinicians that are treating it. Why is the big question. So despite this scientific recognition that exposure is really critical to the success of CBT for anxiety, there are estimates that only 10 to 30% of clinicians endorse using exposure therapy in routine clinical care. In fact, exposure is one of the least used evidence-based interventions, and is rated the most difficult CBT strategy to implement in community mental health settings. When clinicians report using CBT techniques for anxiety, what we hear is that they often opt for the treatment components like relaxation, deep breathing over exposure. So we know that, there are some organizational variables at play here. Organizational culture and climate, are associated with greater or less, CBT use depending on that climate. And when we look at barriers to exposure, the data indicate that these barriers include negative attitudes from the clinician about exposure, kind of thinking that it's not going to be helpful or won't work. Lack of time to prepare for exposures, given the fast-paced clinical life many of us lead. Having little access to materials that might be needed to implement exposures, and not having so many trained supervisors, to be able to oversee exposure activities. Thankfully for us, CBH and Epic are doing their very best to overcome these barriers and make evidence-based practices more widely used. But it's still a lot of places outside of Philadelphia are way behind the times and not doing this kind of work at all. So it's very widespread, the non-use of exposure therapy.